as simple as possible from a postgraduate point of view. And also just I omitted a lot of non-controversial things, just a straightforward things what a PG can answer, right? So the tongue is really an extraordinary creation by God. It's just a boneless mouth that can protrude at will, fold, invert, lay flat, or fill the mouth. So it has such a capability of movement. Along with that, they have a taste sensation. And to date, there is no reconstruction that can match the tongue. So my today's talk will be of these following headings, starting from the anatomy, because I think even Deepak asked a question. You should know about the involvement. So what are the muscles of the tongue? So those basic anatomy you should know. Then functions of the tongue, then algorithm for reconstruction, and how a tongue insert should be, some few flap modifications or the advancement, which you should know. Suppose the question goes long, I mean, you are answering well, then they might ask the other alternative options. Then additional procedures that may have to be done along with the tongue reconstruction, and finally the take-home message. So starting from the tongue anatomy, it's the intrinsic muscle. There are 4 pairs of intrinsic muscles: the superior longitudinal, inferior longitudinal, transverse, and vertical muscles. At least you should know the names, because when you are reading about the tongue, you should know about at least the names. So these are the intrinsic muscles which alters the shape of the tongue. And all these muscles are supplied by the hypoglossal nerve. And extrinsic muscles, again, there are 4 muscles: genioglossus, hyoglossus, styloglossus, and palatoglossus. I think the palatoglossus goes little up. So this is the one when they resect the tongue, you will always see some raw area in the tonsillar region also. That is because of this muscle. When they remove that area also. And so these are the muscles which forms the bulk here it forms the diaphragm of the floor of mouth. So when they remove all these muscles, I think, yeah. Just laser pointer, yeah. So they remove all the muscles. So these are the extrinsic muscles which allows for the protrusion and retractions of the tongue. And again, all these muscles supplied by hypoglossal except by the palatoglossus, which is supplied by the vagus. So coming to the sensation, only the anterior 2/3 is by the chorda tympani and the posterior 1/3 is glossopharyngeal for both the taste and general sensation. And sensory is by lingual branch of the V3. All rest of all the same. And arch development, the anterior 2/3 is the first arch, posterior 1/3 is the third arch, and posterior most tongue is the fourth arch. So these things, basic things about the tongue, you should know, because they can ask from any of these, especially when you're answering well. And blood supply, the main blood supply is by the lingual artery, and the posterior most part is supplied a little bit by the tonsillar artery, and the drainage is by the lingual vein. Lymphatic drainage, anterior 2/3 is by the submental and submandibular. That's the level 1 nodes, and posterior 2/3 is the deep one. But in tongue that can skip, but majority follows this way. So coming to the primary functions of the oral cavity, when you see it is the mastication, deglutition, and speech. If you see the tongue has a role in all these functions. So it's mandatory to reconstruct the tongue first. So the anterior 2/3 of tongue is helpful in the articulation and the mastication, and the posterior 1/3 is the supraglottic propulsion. I think this is the one which we need a mound. That is because of this supraglottic propulsion. And any resection above 30% needs reconstruction. 30% or usually say 1/3 of the tongue needs a reconstruction. So when we don't reconstruct, what will happen? It has a poor control of food bolus, a distorted swallow reflex with aspiration, distorted speech with loss of precision, and absolutely, as he said, that the oral diaphragm is lost, and there's a communication between the oral cavity and the neck. So resection above 1/3 needs a proper reconstruction. Now, there should be definitely goals for our reconstruction. It differs between a partial glossectomy and a total glossectomy. When we say partial glossectomy, our aim is to have the mobility, the tongue have a mobility, should have the adequate volume, then sensation if possible, and shape. It gives an almost a normal, near normal shape of the tongue. So even aesthetic plays when it's a partial glossectomy. But the goal completely differs, is different when it comes for a total reconstruction. Here we need a lot of bulk to eliminate a dead space, that's a filler for the floor, and an obturator to prevent aspiration, assist swallowing, and speech. That is, as we mentioned, touch with the palate. So what are the factors that can influence the tongue reconstruction? First thing, the volume of tongue resection. That is the most important single factor which determines a reconstruction. then whether the floor of the mouth is involved. So we have to design our flap such that it has a more volume if the floor is involved. Then if the mandible is involved, then that takes a priority. Then we have to replace the bone also. Then availability of neck donor vessels, as actually rightly pointed out by Dr. Defect, where if there's no neck donor vessels, then our reconstruction shifts to the pedicle flap, and the choice of flap again depends upon the patient's body habitus. Suppose even I mean, when you say as a partial glossectomy, sometimes the radial flap might be so thin, even the ALT might suffice or a lateral arm might suffice. So the patient's body habitus dictates what flap we can choose, and the potential for reinnervation for some flap doesn't have that sensory branches, and finally the technical expertise and the infrastructure. One thing I like to say here is whenever a PG answers, let him answer. Please answer what you are confident or what you have done in an institution that you might be much more confident in that thing. And the tongue length. So there is no definite tongue length, but actually when we say what we generally, it is usually a rough figure. When we say when there's a total glossectomy, suppose when the total tongue we resected is about 8 to 15. So why I say 8 to 15 is when the total glossectomy is done, usually the resection sometimes goes very deep even into the pharynx. So at that they have to look for it. In such case, you might have a longer skin paddle so that it covers the entire from the pharynx it comes. Otherwise, usually only the oral tongue, it's around 7 to 8 centimeter. And even there has been a study for it. What is the average length by the University of Edinburgh? It's around 8.5 centimeter in a male, and the female has a slightly shorter tongue. And next, it's the width of the tongue. So the width of the tongue is usually it's like a conical shape. The maximum width occurs at the intermaxillary distance. So should you start inserting the flap in such a way that the maximum distance, dimension, the width of the flap comes at the level of the intermolar region. So it's around 7 to 8 centimeter at that place. Suppose in case we are deepithylating the flap on the either side, then a longer breath might be required. Then in a case of a partial glossectomy, when you measure the dimension, should measure in such a way so it will be double the size. Suppose if it is a 2 centimeter excision, then it will be 2 centimeter on the dorsal surface, 2 centimeter in the ventral surface, and side approximately 1 centimeter. So it should be 5 centimeter width if a small partial glossectomy. So it will double the size. You have to fold the flap for the tongue. So this is a rough idea how you have to plan the tongue. And one more important thing here I mentioned, so whenever we say the tongue, generally, I said it's actually even when I was a student, I just was thinking that this is only the tongue. But actually, so this is the only tongue and this is the bulk of the tongue. But actually, what is the tongue is this much is the bulk of the tongue. What we see is only the tongue part, the mobile tongue part, which is above the mandible, but a much bigger part, more than 2/3 of the tongue lies at the level of the mandible, within the mandible, which includes the diaphragm of the floor of mouth, where the muscles of extrinsic muscles of tongue arises. So this much bulk will be required when there is a total glossectomy or a subtotal glossectomy. So this is only what we see here is only a partial glossectomy or only the mobile tongue. But when it involves a floor or the total glossectomy, the bulk required is much more. So we have to design the flap accordingly. And this is the single most important factor that has to be considered when doing a tongue reconstruction. So this is an algorithm which I follow, and it's quite simple to understand. So just see the type of resection, whether it's a partial or a total. If it's partial, if it's less than 30%, we go for a primary closure. Usually you will not be called for such a cases. And when it's 30 to 80% resection with an intact floor, even a radial artery forearm flap or a thin lateral arm flap will suffice. But if a floor is involved, we need a more bulk. In such case, either a lateral arm or a thin ALT or an MSAP or even a pectoralis major, because when it's a very small floor defect, we will not be able to we will not have space for that entire pectoralis major muscle with skin. So in such case, only a muscle will be sufficient to cover the floor and plug the hole. It's just a muscle flap, pectoralis major, muscle flap. So if it is a total glossectomy, then the pedicle flap, the first option will be the PMMC, and the free flap will be an ALT or a rectus. So this is a rough idea, just I will show a few examples. So if this is a case, a small defect, less than 1/3, so it's a primary closure and the post-op. Same patient. And now we come for a partial glossectomy. So in the case of partial glossectomy, just a little short of the hemi. So
yes,
we have done
okay, I am all right.
Okay. Speak okay.
So she is a media person. Even in fact, she joined back the same thing. Such a result we'll be able to get when we have a.
Speech okay. Tongue movements
okay.
Surgery பண்ண எவ்வளவு நாள் ஆச்சு?
It was 20 days.
It was 20 days. So this should be the aim of our reconstruction when we have a partial glossectomy. This is one of the best results. And this is another case to show again a partial glossectomy. Here again you can see that shape, you can get a good bulk shape. So once it mucolizes, you can have
Bangladesh.
Even the flap mucolizes will not be able to understand whether it's a reconstructed or a. Yes, this is tongue. So, and few things in the tongue reconstruction in the partial glossectomy. And for example, there's something called bilobe design. So we always, whenever there is a tongue involved, a little bit involves the floor also, even in a case of a partial glossectomy. So we follow the bilobe, we just give a back cut so that the floor or the ventral surface of the tongue is different from the dorsum surface. So this helps in the proper mobility of the anterior part of the tongue. So this is initially promoted by the first concept was told by Urken et al. In 1994. So we always give a back cut for this, and this type is different when it's a right side or a left side. Suppose this flap is for the right hemiglossectomy defect. This part goes to the floor. This is the dorsum of the tongue. And the radial artery has a lot of advantages: the reliable, thin, single stage, sensate, aesthetically better, good tongue movements, and intelligible speech. The only disadvantage will be a hairy skin, but that also usually it goes after some time because of the contacts with the saliva, and cold tolerance quite uncommon in our part of the world. And again, study shows that in partial glossectomy, a radial forearm gives one of the best results for swallowing and language. When a partial glossectomy is floor, we need a little more bulk. So this is a case of a female patient with a lot of blood out floor. We can need a lateral arm. We can have the bulk is definitely better than a radial forearm, which is able to cover fill the bulk in the floor. And this is again a case of a small floor defect. So here we reconstructed with the pectoralis major only this one muscle flap. So we can one good thing about the muscle flap is it mucolizes very fast. So this is a case, you can see the same patient post-op. Only the muscle flap to fill the bulk. When one more thing in a PMMC, when you're taking a PMMC or a PMMF, if the neck is too tight, probably we might have to sometimes remove the sternocleidomastoid muscle, part of the muscle or the full muscle we had to remove to give the space in the neck. And subtotal glossectomy, and then best choice to be an ALT. You can thin nicely, so it gives a good mount as you can see here. Then the total glossectomy. So here, as I told, the entire floor, we need such a breadth for a case. We need a lot of bulk for the reconstruction. So here you can see once the total glossectomy is done, what you will see from the neck is the palate. So we have to create something. And one more thing I want to mention here is the entire surface here, the raw surface, the mandible should be free of all the residual mucosa of the tongue, so that we attach the flap. The insert of the flap is to the teeth, like interdental sutures, so that the flap stays above and there is no mucosal contact. Because if there is a mucosa, we will not have a proper healing of the flap skin to the mandible, and there's a chance of OC, orocutaneous fistula, is high. So there's high chance that all the remaining small mucosal big tissue will go for a necrosis because they don't have a good blood supply. So all the residual mucosa should be removed before inset. So it's a case of total glossectomy. For example, you can see the PMC, the muscle. It has a very good subcutaneous fat, and this is the defect covered. So initially it has a good bulk, but most of the time, if you see later, the bulk goes and we form only a trough. And here with an ALT, you have a good bulk and it also good nice mucalization. And here, just as the presenter mentioned, first the medial incision made. Here we need a little more bulk. So what we did is we planned for this is the two perforators. Then we planned the muscle based on that perforators. Here the muscle was lying loose, so we just had some sutures, drill holes in the mandible to fix the muscles. So this is the muscle harvested. So we can decide how much muscle we want, and this muscle can be inserted into the mandible. This gives a much stiffness and filling the floor, and even the vastus lateralis nerve was sutured. Then ALT we can also design the flap. So this maximum, I'll just show pointer. So where the maximum width at this point comes with the intermolar area, we can where the maximum width of the flap will be required. So this is the pre-op of the same patient. Andhra. So the post-op. Usually speech will be intelligible, but it will little leathery speech will be there. They will not be. And you can see the mobility. Good mucalized tongue. It's a good mobility, and you can see the insert. It goes even up to here because they remove the muscle along with it. Usually the raw area extends up to here. So in PMC, as I already mentioned, it's compared to ALT. Though it's called as workhorse, it's less time consuming, but the disadvantage is skin bite is less reliable compared to muscle. It can't be sensate, sags down due to gravity, hampers mobility of tongue, fails to provide required bulk, especially after few months, and poor speech and swallowing functions. It's a comparison of the ALT with the PMMC. And sometimes the bone might be excised along with the flap. Here actually the bone was excised. So this was reconstructed with the fibula. Actually, this patient had a good bulk, so we took a lot of, soles also along with it to fill the floor. And part of even the skin puddle was deepithelialized and brought to the floor to give the bulk. So this is the post-op. And so coming to the insert, so we know there is a flap harvest is there and anastomosis is there. In between, there's something called flap insert. It's very important in tongue. So this is what we see in that. We see in a defect in the case of a total glossectomy. So what we need is a watertight closure. So as I already mentioned, all the insert initially starts from usually this is the pharynx. Usually the flap ends here. So if the defect extends down, then the length of the flap required will be much more. So we start inserting from here. And this is the area where we have the maximum width of the flap that is required, which usually around 7 to 8 centimeter. Then once it comes here, usually might have to remove the third molar. Usually at that point, the flap will have a, usually it will be difficult. Otherwise, it will be coming over the teeth. So that area, the teeth might have to be removed to have a proper insert. And then the flap is transferred to the oral cavity and the remaining sutures completed within the oral cavity. So just in the flap insert, especially in a tongue, start inserting from the neck after positioning the pedicle, insert up to the RMT region, then flap delivered into the oral cavity, remove last molars if needed, confirm the removal of mucosa on the lingual side of the mandible. It's very, very important because if this is a high chance that there could be a salivary fistula into the neck. So, and your anastomosis in the neck. So very much careful so that we try to insert as much as possible into the proper insert into the mucosa. Any mucosa, if it is especially in the pharyngeal level, if it is used by the oncosurgeon, if there's too much of cautery, just excise it so that the bleeding is good and then start inserting and have a proper interdental suturing so the flap stays in place. And if there's an excess muscle, then fix it to the mandible or keep it in a proper position so that the entire cavity is, it acts as a filler. And as she rightly mentioned, the presenter mentioned, we have the hyoid stitch. It's taken between the body of hyoid to the drill hole in the mandible. This improves the post-operating swallowing ability, minimizes the surgical defect, and also this actually here the shifting of mandible might not be required here, but it has an added advantage of that also. The ancillary procedures which we do along with is you should always mention a patient will go for a tracheostomy. For any head and neck surgeon will say that in a tongue cancer, the threshold for creating a tracheostomy is much low. So even the small buccal mucosa, we can avoid a tracheostomy. But the tongue, the problem is once we have a tongue and sutured flap is reconstructed, initially the patient will not be able to move the tongue. So the tongue will be tethered, so the chance of aspiration is very high. And post-operatively, the patient goes for an edema. Sometimes it can block the breathing, even the breathing. So most of the times, even the smallest doubt, they will go for a tracheostomy. And there's no doubt in a total glossectomy, always a tracheostomy is done. That should be mentioned in our presentation. This is to prevent the swelling in the post-op period and also to prevent aspiration. And again, another important point is nutrition. This patient will not be able to take by mouth for a minimum of 2 to 3 weeks. So a nasogastric tube or Riles tube should be placed in situ. For a patient have a long duration of aspiration, sometimes even a PICC placement will be required. Then what are the flap modifications that can be done? As already mentioned, motor neurotisation, where we join it to the hypoglossal nerve. The sensory neurotisation, where it is joined to the lingual nerve. Then designing the flap depending on the defect of dimension, the site of perforator, and the primary closure of the donor site. So the flap, these are the flap modifications that we can do. And finally, the flap insert. So it's like our grandma's money pouch design. Packing too much of flap inside the mouth. Taking this white stitch, horizontal matter stitches, less within the teeth and more of the flap, so that the bulk of the flap increases within the oral cavity. It's a money pouch design so that more bulk comes into the oral cavity to create a mound. So this is one case of the defects of total glossectomy, where we done the neurotisation, and you can see the Vastus lateralis nicely fills the floor. Taken few stitches here within the mandible and few within the neck skin. And other options, what are the other options that can be followed in a case of a glossectomy? Total glossectomy is Gracilis myocutaneous flap. And this is one for so there is a small, these are not actually, I have explained this. Just when
we got our seminal publication with Gracilis and gastromental flap.
Yeah, that will be coming there.
Oh, sorry.
Yeah, so this is a small defect. We can take a brachioradialis along with the radial forearm flap. And this is from the Amrita. So where they have done a functional reconstruction, the entire tongue was reconstructed with the gastro-omental flap, and for a dynamic gracilis, which is between the hyoid and the mandible. So this provides the mobility or the superior movement of the tongue, and this forms a natural tongue mucosa. This is actually a double free flap. And definitely we need a good expertise and a good team to perform such procedures. You should definitely know these procedures. And even our moderator Sandeep is one of the author here. So we should have these things. You should know. See, we might have done few or you have seen, but these things you should know. At least a few. That's why I just presented a few modifications which you should know. And this it has been present from India. So the more the chance that you may be asked a question in this. And what is again the most important thing, I just want, these are the slides. So what are the factors that affect the functional outcome in a tongue? First thing, the most important is extent of tongue. For example, in a partial glossectomy, whatever the residual tongue, they are only going to move, and we put a flap, it's just going to stay as a piggyback to the native tongue and have to move along with it. So ensure that the insert which you give does not prevent the existing mobility of the tongue, and whatever the tongue that's remaining, that is going to move the flap also. So the most important thing affecting the functional outcome is the extent of tongue resection, or what is the amount of tongue that is left, and the floor of mouth resection. Because once this is done, the movement of tongue is totally affected, and the volume, we have to create a bigger volume is required, and such patients have a little poorer function. Then if there's a mandible excision, it has a poor function. Then type of reconstruction, this I've already mentioned multiple times. Free flap reconstruction is much ahead of a pedicle flap. And patient motivation, again, this is a quality of life questionnaire, shows that a speech and proper speech and swallowing therapy and good family support as a good functional outcome. And the site of in a partial glossectomy, a lateral resection, just one which I showed, as a best post-op function, and a younger age has a better function. And post-op, both post-op radiotherapy and chemotherapy has a detrimental effect. Then, having said that, factors not affecting the functional outcome is that still now, it's one of the very recent paper in 2017 says that no definite evidence suggesting that one type of flap leads to superior speech outcome to other. So even a free flap, whichever you are comfortable, convinced with, then you can go with that. So one flap doesn't have an advantage over the other flap, and there's no definitive evidence to suggest that a re-innervated flap has better speech. That can improve the sensation, but that is not going to increase the speech. And this video swallow studies say that patients have demonstrated a return to preoperative swallow parameters by 1 year post-operatively, regardless of the flap type. This again something different of the a little bit same what the first line says. So the respect of the flap type, the result is going to be the same in 1 year post-op, and renervation is not going to improve functionally the speech, but it provides an added advantage of the general sensation in the tongue. And quality of life, I mean, it is it reduces in the immediate post-operative period, but 1 year, after 1 year, usually it is almost reaches the pre-operative stage if the reconstruction is good. So just I want to again, tell again what is the algorithm which I follow. Just we can have, this is a non-controversial thing. You can take it as it for your examination, depending on the type of resection, whether it is a partial or a total. If it is a partial, less than 30%, go for a primary closure. If it is 30 to 80% resection, just identify the intact or the floor, intact floor, or the floor is involved. If its floor is intact, then you can go for a free radial artery. If the floor is involved, a lateral arm, a thin ALT, pectoralis with muscle flap, or a MSAP. So total glossectomy, it's a pedicle flap PMMC, free flap, ALT or a rectus, and ALT and AVB should be the first option. And finally, the take-home message: in a partial glossectomy, our aim is to have a functional and mobile tongue, and radial artery is of choice. And subtotal total glossectomy, tongue cannot be reconstructed to recreate fine movements, but the aim is to preserve swallowing and add bulk, and free ALT is better than a pedicle flap. Thank you.
Selva, wonderful presentation again. Great presentation.
Yeah, Selva, that is an awesome presentation, Selva. And I love the way that you have actually given so much importance to the flap inside, because actually when we see, we see so many talks where the reconstruction, the various flaps, etc. is actually emphasized. But the very important thing is the importance of giving the inset. You have given so many practical details of how you actually go for interdental fixation, how that it has to be watertight. And normally we know that if a particular there's a problem, if the inset is not given well, actually the flap will be doing well probably for the first 4 days or 5 days or so, and then slowly what happens is that there's going to be infection in the neck where the anastomosis is done and the flap is slowly going to die. So it is very, very important that the inset is actually given so well. And I love the way that Selva has actually given so much of importance to the inset. And of course, the algorithm was also very simple, so that every one who's actually watching this would be able to easily remember it and then answer in the exams also on the various sizes and the importance. All those things you have covered so well, Selva. Thank you very much for that wonderful presentation, Selva.
Yeah, thank you so much. Thank you. Thanks for the opportunity. I think I have given justice to your selection.
Wonderful, wonderful, fantastic.
Thank you so much, Sandeep. Thank you so much.
Just one question has come up in the chat box. If I can just ask you, Dr. Ravi Kumar has put a question. Can we do PMMC for carcinoma tongue, keeping the mandible intact?
Yeah, definitely. See, because normally for a buccal mucosa, we always say with the intact mandible it's difficult. But the floor of mouth, it is very easy because it is just opened here. We are going to give insert from inside, so it's not an issue. With the intact mandible, we can give a PMMC in a tongue CA, and that is the way it is done.
Okay, thank you. I think it is somebody has raised the hand. I think it's Madhavi, right? Madhavi, did you raise a hand?
Yes, sir. Yes, sir.
Yeah,
Sir, I have a question to ask. Sir, let us say this patient had no previous it was not a recurrence, and there is involvement of the mandible, and we do a segmental mandibulectomy, and we have planned for a PMMC. This is a very extravagant planning, but just say we have planned a PMMC. Do we have to reconstruct the mandible, the segment that has been removed? Or will the muscle act as this thing?
See, when we say, just say what I will do. See, in case if the mandible is involved in that, it depends upon which part of the mandible. If it is just the posterior segment, you can even neglect. Even if tongue, you can just put a PMMC and come out. But in case if it is a lateral segment, it's a bigger segment, then that also takes an equal importance. We should reconstruct the mandible. If facilities are available, my first option will be a using a fibula, and you can modify the flap accordingly and reconstruct the tongue also. You can take a more of soleus and a bigger paddle depending on the side which it, you have to design the flap accordingly, and you can take a little bit of soleus also, so you can define the fibula flap accordingly, and you can reconstruct both simultaneously. But facilities are available. You can there are also descriptions saying a fibula with a PMMC, a fibula with another ALT has also been described. So it's up to you what you want. So it depends upon which side of if a small segment only posterior with ascending remit, then you can leave and reconstruct the mandible and come out. Otherwise, you have to do both.
Only two
And
things
sir,
important.
sir, I have one more question.
I only have two things important. Is the patient dentate, and what is the age of the patient? So I wouldn't mind doing a double free flap. I have one of the largest publications of double free flap for patients. If the patient is young, if the patient is dentate, I don't mind spending 14 hours in theater, but I will retain the occlusion, I will retain tongue propulsion, and I will do a double flap, can be one free flap, one pedicle flap, or two free flaps. I have done that about maybe 50 times now, where lateral segmental and total glossectomy patients have come. But I would see the dentate state of the patient and their preoperative swallowing assessment. So doing a pec major for a tongue is really bad because there's a lot of pull and there's a trough created. I would rather do a a fibula with an ALT or fibula with soleus where I can get some bulk to the skin paddle. So it's not a very easy decision to make. And if people tell you it's an easy decision to make, it's wrong. I mean, I'm not a plastic surgeon. This is what I've realized from more than 10 years of experience. So I would do two flaps. Sorry. Sandeep sir, Silva.
Deepak, another question, Deepak. Is
Please
there
ask.
any change? Deepak, would you have any change of plan depending on the area where the mandible has to be resected?
Yes, sir. If it's a mental defect, if there's a defect between the two canines, there is no doubt that the mandible has to be reconstructed. But if I have a preoperative patient who has got good swallowing, I would do just one flap, that is a pec major ALT for a lateral mandibular defect, because we can train them with interdental elastics for occlusion. So they'll be able to occlude from the opposite side with their maxilla and mandible and an ALT flap on this side. But it's a mental defect, young patient, good occlusion, and a significant bulk of tongue resected. I would spend 14 hours doing two free flaps.
Correct. And absolutely, because that we have
Sir,
to suspend the muscles also, right?
I
To
will
the
suspend the hyomandibular thing, and I will do a aryepiglottoplexy also, where the both free flaps from both free edges from the. This is something that has not been mentioned by Selva. I would like to add on to this. The hyomandibular suspension is bringing the larynx closer to the mandible, meaning that you are pressing the epiglottis against the mandible, meaning the epiglottis goes over the larynx. But that is not enough because the food will just go over the larynx into the piriform sinus. But you have to do aryepiglottoplexy also, meaning you have to cut the aryepiglottic fold in the medial aspect and close it over the larynx. Sorry.
That's, I think some other talk has come in between.
Madhavi said
Yeah,
something. Madhavi,
continue. Please
say
continue.
that again.
Please
It
continue.
wasn't me, sir. It wasn't me, sir.
Sorry. So you have to do hyomandibular resuspension and also do aryepiglottoplexy. It is very difficult because I do it for every case where you take the medial aspect of every epiglottic fold and suture it onto itself, thereby reducing your supraglottic isthmus. Otherwise, patient will aspirate and die because you've got.
Aspirate.
It is a big problem, sir.
Because I remember because when the earlier cases of total tongue was done, it used to be actually a permanent tracheostomy for when some
Correct. It is
yeah.
permanent always, sir. You cannot reverse, sir. And remember one thing, sir. ALT will not be susceptible for hyomandibular resuspension because your proline stitches will compress against the ALT pedicle.
Okay.
So only rectus works.
Okay.
Because rectus is from lateral to the muscle. So you can resuspend all the muscle you want and take the perforator and the pedicle from lateral to muscle to your neck.
Okay.
So this hyomandibular resuspension doesn't work except for rectus, sir.
Okay. Okay.
It doesn't work. And the lower we go down in the rectus, the lower we are sacrificing the rectus sheath, because higher the rectus, we have the posterior rectus sheath intact for us to take the flap. But it makes
Right.
our nerve segment short. So if somebody is planning for hyomandibular resuspension, please, as a plastic surgeon, please consider rectus. It's a brilliant flap, sir.
Because rectus sheath itself is going to give a lot of strength to the floor, right?
Superb strength, sir. Superb strength.
Yeah.
Because the muscle is above that.
Okay,
The
fine.
muscle is above that, and multiple periumbilical perforators are above that.
Okay.
You look at
Got it.
ALT's perforator system. We are trying the hyomandibular suspension with the pedicle below the proline stitches.
So when you're using the rectus, your muscle is going to be raw muscle. You're not going to do anything for that muscle. You're just waiting for that to mucosalize.
Yeah, we are
Because
raw.
Selva showed a lot of beautiful pictures of raw muscle mucosalizing. No?
Little bit of umbilical skin, not much, little bit. But our abdominal surface is raw only with one rectus sheath. Then we have to understand patients who have COPD, pregnancy, obesity, who have divarication, all those things we have to see.
Okay.
But that is the best flap, sir, because rectus muscle is thick, abdominal muscle is thick even in the worst patients. We can anastomose the segmental nerve to the hypoglossal nerve, and we have good pedicle length.
Yeah. Selva, you want anything else to add as a parting thing?
Selva, have you done
It's almost 8 o'clock.
Rectus, it's almost I can talk for another 1 hour. Selva, நீங்க பண்ணிருக்கீங்களா? Have you done rectus abdominis for total?
I have not done rectus.
Oh, okay.
I have no experience with rectus. It's one of they have told one of them. Probably next case, probably I will try.
It's actually really good, but the only problem is our patient habitus is totally weak, Sandeep sir. You look at all the patients; they're so malnourished, and it's not a question of the surgeon; it's a question of the patient. Yeah. Lakshmi ma'am also will say, how many, Lakshmi ma'am, you tell me how many patients you've seen with good rectus girth for us to do flap, ma'am?
Yeah, because the tongue patient already will be emaciated to some extent.
Yeah, it'll be emaciated because of that. Yeah.
So,
Dr. Lakshmi, I think it's been a long day today. It has been wonderful. A lot of discussions has been going on.
One session, I think.
Yeah.
And
so
academic
please, you can do the honors of doing the word of thanks, right?
Yeah.
Hello.
Radha.
Hello.
Radha.
Sandeep, my video is not working.
No problem. We can hear you well.
Sir, we can hear you, sir.
My video is not working, Sandeep.
Yeah. Sir. We can hear you. Sir, we can hear you,
Thanks
sir.
to Selva Seetharaman and Deepak.
Yes, tell me, sir. Able to hear it, sir.
Presentations and the case discussion also was very fine. But I just wanted to ask Deepak one small doubt.
And making money now.
Hello.
Sitting in his office also.
Radharshan, tell Radharshan.
Sir.
Yeah. Radharshan, I think you wanted to ask some question to Deepak, no?
Yeah.
Yeah, please.
Anatomical dissection, how anatomical neck node dissection, how is it related to this embryonic origin of tongue growth? Embryonic way of considering the tongue. Any relationship between that?
Sir, yours is a very smart question which hasn't been answered for 30 years now.
That is what. See, most of the, every now and then I just
me, but you probably heard it and read about it for the last 10, 15 years. There is no relation, sir. It's all the embryonic containers that we have, which have metastasized from the tongue to the neck nodes. And the embryonic containers have been defined by Rouvier in the 1600s. So we're talking about 300 years history now. Hasn't now, after Jatin Shaw published in the 1980s, 1990s, we have found an orderly way of metastasis from tongue, buccal mucosa, maxilla to the neck nodes. But how is it related with the pathology? We don't know, sir.
Because 1990s, once the 1985 to 90, once the level of nodes came into existence,
nothing we know, sir.
Yeah,
your point is extremely valid and extremely right. I have read thousands and thousands of papers. Sandeep sir will attribute to the fact. I haven't found any embryological data to support or to say what you're saying, sir.
Ultimately, you're going to have a fixed levels of lymph nodes that you're going to take it off. You have to have something like a protocol-based removal of the lymph.
Exactly. Yeah.
We are 400 years ago, sir. We don't have any data after that.
Because there is, I mean, nobody has categorically mentioned that this origin you should touch only these nodes. No need to go this.
Right, sir. There's nothing.
Yeah, as it has been done in carcinoma stomach.
Like even
nothing, sir.
Yes, because carcinoma of the stomach, the Japanese fellows are very clever. Like I mean,
that is different. That is D1, D2, D3. They have multiple. See, in Japan, the carcinoma stomach is 60% the patient population. Our D1, D2, D3 restrictions are quite different because they had clinical data to support it. We don't have clinical data or embryological data to support anything. And Japanese data is different, sir. Our gastric data and esophageal data is much different what we have done, sir.
Yeah, that's what. So
I am surprised you have taken the D1, D2, D3 data from Japan.
Yes. Because time immemorial, we have been listening to these things, embryological and nodes and other things.
Selva will tell you all the things because Selva has general surgical background. Selva, D2 resection stomach MSc la panningla?
No.
I don't know anything. So leave me alone.
Things are of historical importance rather than probably.
No,
I mean,
I have read all the pregnancies, but the stomach and our head neck has not been really proven so far, sir.
But
so I think
once again,
just wait.
Once again, these Japanese people have gone to now. We are coming to secretary and functional part of reconstruction of tongue.
Different level, sir. See, their population is 11 million. They have gone to a different level altogether. Number of population is so much.
Yeah.
They have gone through a different level.
They have gone to the level of intelligibility in tongue reconstruction. That levels, those papers are.
Sir. Number India Tata has gone through a lot of tongue. I don't believe that. I don't know the oncological aspects, but I still think Tata, Hyderabad, and Bangalore and Amrita, we have done a lot of good things. Sandeep